Professor Zahran.
Thanks a lot. Thanks a lot for the kind introduction, and thanks a lot for the kind invitation, and congratulations for the wonderful world-class conference. Professor Omar Awad, Professor Mohsen Ibrahim, and Professor Sulaiman Gharib, and all my professors, thank you so much. So Professor Mohamed Abdelghani, I'm really honored when he called me to invite me to present a case today, and he told me he would like to see an interesting case involving an interesting case showing something related to hypertension with an interesting clinical scenario. So this is one that I hope it may be a little bit interesting because it's not common to see. So not to waste more time, this was a 34-year-old gentleman. He works as a lawyer, and he presented to the ER nearly at 2 a.m. in the morning with headache, chest pain, pre-syncope, and he was put on an immediate monitor, and ECG was performed in the ER. On examination, I was told that his blood pressure was 180/110, which was equal from both upper limb, and the patient was congested with fine basal rales, and there was a murmur of mitral regurgitation that was heard on his apex, and he was monitored and ECG was performed. So the resident told me that he caught something like a severe bradycardia on the monitor, which was just caught in the first 2 or 3 beats on this one, and then the regular ECG was recorded. So the heart rate here is nearly around 30 beats per minute, and then here you can see that there is an inferior ST segment elevation with ST segment depression in the chest leads and the lateral leads. So I told him to repeat the ECG after 10 minutes. And after 10 minutes, he got this ECG, which was a rapid atrial fibrillation at a rate of 130 with a clear inferior ST segment elevation with reciprocal depression in the chest leads and the lateral leads. So this was a classic case of inferior ST segment myocardial infarction associated with intermittent heart blocks and atrial fibrillation. The relevant history of this patient that has been hypertensive for the past 5 years, he is uncontrolled and he's not compliant on medical treatment. He's occasional smoker of cannabis, and his friend said that that night before they came, they were smoking together, but of course the relative said our son is an angel. He's dyslipidemic, he was not compliant on the medical treatment either, and he has a strong positive family history of ischemic heart disease. His father and his uncle, one of them did a PCI and one of them did a cabbage. So the immediate management in the ER included loading by ticagrelor, rosuvastatin, aspirin, and he was given 80 milligrams of furosemide for the pulmonary venous congestion. And he was prepared for primary PCI. This is the ER data, as we said previously. And in the cath lab, when I arrived, 30 minutes, the patient was impending pulmonary edema. His chest showed the murmur of severe mitral regurgitation, and I ordered him to be put on a CPAP and ventilated non-invasively to start the primary PCI procedure. While performing this, I have the portable echo in the cath lab. So we did a bedside echo while he was being ventilated, and this showed an impaired ejection fraction, 35–40%, akinesia, infraposterolateral, big segment, severe mitral regurgitation, mild aortic regurgitation, no effusion, no VSR, okay? So this is the data that I got by the bedside echo while I was preparing the patient for the PCI. I did a right coronary artery injection, a small, non-dominant, normal, 34-year-old vessel, very smooth. And when I injected the left system, something caught my eye here in the LCX, if you can see up there. I focused on it. It looks like there's a dissection or haziness in the circumflex artery here. And this was in the era of COVID and everything, where everyone was minded about spontaneous coronary dissections, MIs presented in young age, and so on and so forth. I took the cath out. I started giving non-selective injections. The left LAD and the LCX appeared arising by separate ostia. So one injection gets the LAD, the other injection gets the LCX. The LCX retains the dye a little bit beyond the LAD, but I cannot recognize what's going on. Is there a real flap of SCAD? Why is this patient getting an inferior MI, a complete heart block, and so on? I finished my injections. I was a little bit confused, so usually we go to the room beside us and let's see what's going on in the control room, what's going on with this patient. My diagnosis provisionally was maybe a SCAD or something, and this SCAD healed or was resolved by the flow of the blood or so on, so I do not need to do something urgent. And then suddenly, the patient developed acute chest pain and his blood pressure dropped to 50/20 inside the cath lab on the spot. So I took a guiding catheter, I took a floppy wire, and I injected, and I did not find any LAD or LCX, and I could clearly see a flap of dissection in the ostium of the LCX. So probably there was a SCAD, and this SCAD propagated proximally to involve the ostium of the LCX, and now it's involving the ostium of the LAD, so the patient crashed. So very quickly, I passed 2 floppy wires successfully enough. Once those floppy wires were passed, the restoration of the flow was there, and I passed a 4.5 millimeter onyx stent to stent through the left main, but there is no left main actually, to the ostium of the LCX, which was clear here to show that this ostium is actually near totally occluded because of the flap. Mohamed Zahran, why are you presenting a case of STEMI in a hypertension meeting? I'm so sorry, guys. You will see. So this is the stenting procedure, and we got an excellent final outcome with a flaring and so on. So now we are good. The patient is very stable. The ECG is completely normalized back to normal. The ST segment is resolved. The patient is in sinus rhythm. And happily ever after, the hero doctor at 2 a.m. saved the patient. But life is not like this. So next day, this patient will do what in the CCU? We'll do an echo, a regular echo. And we did a regular echo showing a regular ischemic patient, improved function, segmental wall motion. And then the operator called me saying, Zahran, there is a dissection flap seen in the ascending aorta with severe aortic regurgitation. I said, what? Dissection flap where? Causing what? Okay, so we called the cardiac surgery. We stopped the ticagrelor for 5 days, and thanks God, we had a 4.5 millimeter short stent. So the patient did not develop stent thrombosis. He underwent a surgical repair for a type A aortic dissection 5 days later, just a simple aortorrhaphy, not involving something like changing the aortic valve or mechanical valve or something, and he was discharged after 1 week from the aortic dissection repair. Pre-discharge echo, 50% ejection fraction, moderate mitral regurgitation, mild aortic regurgitation, no wall motion abnormality. So what do we learn here? Hypertension alone may be a part of a bigger clinical dilemma. Hypertension definitely is a risk factor for ischemic heart disease. So when you get an MI and the patient is hypertensive, you're not so puzzled. I mean, it's not a surprise. Hypertension is a risk factor for aortic dissection, and most of the patients with acute aortic dissection might be hypertensives. So this is also an association. Both of them cause chest pain. Aortic dissection might involve the ostium of the coronary mostly, or most commonly, it's the ostium of the right coronary, but sometimes if you have an LCX with a separate ostium, you might get that, and you get the STEMI in the ECG, and you do the primary PCI procedure. Severe hypertension can cause pulmonary congestion. Mitral regurg secondary to inferior MI to a circumflex can be ischemic, and it can cause also pulmonary congestion, and you never know the difference. So the points to consider here is that what you study in the book is not necessarily what you see in the practice. So it looks like a duck, it quacks like a duck, it's a duck. It's yellow and slim and the fruit, it's a banana. But you can see this. Sometimes you meet those kinds of patients in the reality. Thank you.
شكرا محمد على this nice presentation for a case we are can see every now and then in the emergency department. One of the dilemmas when the patient is presented by chest pain and severe hypertension, that the residents or the one working on the emergency room, all his mind, blood pressure is 200/100. The very bad mistake that they start to cause sudden drop of the blood pressure by this mistake of putting some medication under the lung or crushing some medication, and this is a heroic type of presentation. I think in these conditions, better to relieve the pain, and most of the patients, if they are presenting with chest pain, they will be improved. The second dilemma we are facing in a case like that we find, as you described, that the patient is having severe mitral regurg, and he has a coronary artery disease. Whether correcting the coronary artery disease will help because this is papillary muscle dysfunction, or whether we are transferring this patient to surgery, what is the best solution? In this condition, we are knowing that we are in a fight with time. We have to deal with the coronaries in order not to cause a damage to the myocardium. And if it is remaining, there is a good possibility that the mitral regurg will be improving, especially if it is an inferior infarction. But if there is no enough improvement, we may repair. But the most important thing here is to save the myocardium. What's your comment about that?
Yes, the important thing is to save the myocardium. And as you said, Professor, this is a part of the whole clinical context. This is the 34 years old, very smooth coronaries, a clear inferior MI in the ECG, and a heart block, and then rapid atrial fibrillation, and so on, with an ischemic mitral regurg, acute pulmonary edema. So this is the context that we are seeing. Whether this CAD is associated with an aortic dissection or not, or whether this, what we saw in the proximal CX, and then we saw in the left main, or whatever it's the left main or not, and then it might have extended to the aorta. I mean, the dissection started in the coronaries and extended to the aorta, or the dissection started in the aorta and extended to the coronaries. We don't know, but at the same time, we got the two pathologies at the same day. The chest pain was overlapping between both. The MI was clear in the ECG. The aortic regurg was not apparent in the bedside echo, probably because of the low resolution, or maybe it was at the beginning. And the next day, with improvement of the myocardial function and the blood pressure was high, and we didn't reduce it rapidly, as you said, because he was in our CCU. So maybe this sheer force propagated the aortic dissection more. I'm still puzzled by this case. I've only seen this one and one when I was a resident like 15 or 20 years ago. Only two cases I saw. One of them was an inferior MI involving a right coronary with an aortic dissection, and this was managed conservatively. No stent was inserted, but here I had to put a stent because the left main, or even the ostium of the LED and the LCX, both of them were occluded at the same time.
If there is any question from the, yes, Dr. Suleiman.
I think this patient may have a connective tissue disorders. He has a mitral regurg, aortic regurg, and dissection of the aorta. And the cause of the progression of the disease is the presence of dissection in the proximal part of the circumflex. Because when we open the circumflex, the condition improved.
Yes.
If the condition purely due to aortic dissection, the condition will not improve. Therefore, we have to study this patient carefully. Yes. This patient has
connective tissue disorder.
Connective tissue disorder for sure. It may be like Ehlers-Danlos, mitral valve prolapse, and so on.
Yes, I totally agree.
Dr. Badr?
Shukran, Doctor. I wonder really whether this is a 37 years old young man with 5 years of high blood pressure. It might be even 5 years pre to the 5 years. We don't know. Would you think that there's a probability of secondary high blood pressure and not only the cannabis intake? This is number one, which we have investigated and enforced the message that Dr. Suleiman was trying to address. The other issue in the acute management, having furosemide given to a patient who is having an impending severe secondary cause possible for that, would you think played a role in the drop of his blood pressure? I wonder what was the timing between your theater and
30 minutes. Yes.
Thanks.
So the patient has an impending pulmonary edema and a very high blood pressure. So he will take diuretics for the pulmonary edema because I will not ventilate him as the first step. So he took 80 milligrams IV in the ER, and he was in the cath lab 30 minutes later. While he was in the cath lab, his blood pressure was fine, and his crackles were increasing. So now we have a normal blood pressure and we have a pulmonary edema. So I put him on a CPAP. And then I started my job, and then I finished. The ECG normalized, everything is fine. And during which the left main was occluded. At this point, the patient cracked. So the patient crashed when there is no LAD and no LCX. Once they were opened, the patient is fine. The ECG is totally normalized. And actually, I believe that maybe what was going on with the intermittent heart block and then the rapid AF, that this patient had the flap going like this. So the flap might occlude the ostium at the LCX at a point, and with some other beats, it might relieve this occlusion, so the patient gets something intermittent going on.
Dr. Fathi?
Thanks, Professor Mohamed Zahran. Nice case. Actually, it reminds me by two cases I faced more than 10 years while working in Saudi Arabia. One of their similar scenario. One of them is about 40 and one is 45. And the second one was staff in Ain Shams University, one of my colleagues there. The issue of presentation is very important, as you mentioned, but also, there is some points should be considered in case a scenario which is not straightforward with inferior infarction. This was not a straightforward of inferior infarction in the presence of severe hypertension, in the presence of dissection, as you said, in circumflex spontaneous dissection as a SCAD, and the SCAD, you know that it's not common in male, yes, more in female, and the presentation usually in the LAD and dry coronaries, difficult to be in the circumflex. And even if you manage SCAD with wire and stent to be deteriorated more and patient improved. What I mean, there is a different scenario which is not going with simple inferior infarction.
Definitely.
And the presence of severe hypertension, even with bilateral equal pulses, we should consider dissection.
Yes.
And that's why the echo Doppler is very important before you intervene in like these cases.
Yes.
And sometimes in our cases, we did CT angio at that time, and we found a severe dissection, including that's right coronary mainly, and the other one was not including right coronary. What I mean, CT angio is considered one of the important points when you have a presentation which is difficult to say it is straightforward. And it's one option of the early triage of severe chest pain.
Yes.
So I think, and this may help not to give aspirin, you give aspirin, Blavix, and intervention, which is not suitable.
Yes. They did that because he had
in patients with dissection.
They did that because he had an inferior STEMI. So you cannot decline the inferior STEMI. If this scenario was in any other scenario with a normal or a vague ECG, this would be perfectly fine. But you have a clear inferior STEMI. What would you do?
Even with the clear inferior, you know, dissection of ascending aorta,
yes, I know,
usually going to the right coronary.
I know.
This may one of the presentations.
You will give definitely.
I mean, meticulous echo before setting of intervention is very important.
Yes.
Most probably echo was.
We did so.
It was missed.
I don't know, it missed or it was in the beginning. Maybe.
Thank you, Dr. Ahmed. Dr. Mohamed, you did an echo before.
Yes.
And the echo showed mild aortic regurgitation.
Mild, yes.
Did not show the flap.
It did not show the flap.
So this is with that this event has happened after you did
I think in the next few hours between the night and the morning when he did the echo.
Could it be catheter induced?
Might be, I don't know, but I mean from the first injection, you see that the flap is in the LCX away from the ostium. And then after 20 minutes, when you were reviewing the angio, it was involving the ostium. And the next day, it was involving the aorta. So I guess it was something propagated. The separate ostia here made the LCX behave as if it is a right coronary. It's not like a left main, bifurcating, and so on. It's a circ with a separate ostium.
Okay, thank you very much.
Thank you, sir. Thank you.